next speaker, who is Dr. Rahul Shivare. He'll be talking about updates in management of heart failure with preserved ejection fraction, a role of liver agents. Dr. Rahul is an international cardiologist at Magnum Group of Hospitals in Nashik, and he's done international fellowship at Mount Sinai Hospital, New York, USA, and he's done DM cardiology from Bombay Hospital Institute of Medical Sciences, Mumbai. He is highly experienced in cardiology procedures, balloons and devices, and he's previously worked at Bombay Hospital Institute of Medical Sciences, Mumbai, and Shri Sai Baba Sansthan Trust Super Specialty Hospital, Shirdi. So over to you, Dr. Rahul.
So, good evening, everybody. Myself, Dr. Rahul. Thank you, sir, for very kind introduction. And without wasting much time, as we are already running behind schedule, I will continue with the talk, which is focused on heart failure. And as my previous speakers, Dr. Seema and Atul sir, they have made my job a bit easier, because today I am going to touch upon a very different topic, which is very common but yet untreated, undiagnosed. So Vijan sir, I gave this terminology, that is HFpEF. Everybody is aware of HFpEF, that is heart failure with preserved ejection fraction. So what it is, we have to understand first. What I feel and what my cardiology colleagues will agree with me, that it's very common thing, very commonly present in the society, undiagnosed and untreated. And the P, that is P in the preserved ejection fraction group, let us understand it with the analogy of pollution. That is, pollution is very common in our society, be it air, water, industrial pollution. But you have very less solutions for that, if sir may agree. So the analogy of pollution I have given to the preserved ejection fraction, that is HFpEF, that it is common, you know it is there, problem to hai, lekin solution bahut kam hai. So same thing is true with HFpEF, that is heart failure with preserved ejection fraction. Why? Because reduced ejection fraction, we all know the pillars of treatment, the continuum of the therapy, and the gold standard therapy is already proven, easily available, and we have already achieved the endpoints of reducing the mortality, morbidity associated with heart failure, reduced ejection fraction. But what about HFpEF? That is heart failure with preserved ejection fraction. It is unknown, and till today we had very few options available with us. And hence, I have labeled this as SGLT2 and ARNI. With the advent of these two new molecules, do we have something new, or do we have something, finally something which we can effectively treat HFpEF? And hence, they may be new kid on the block. Let us see what the data says. So before going further, let us understand the terminology of heart failure. Dr. Seema madam has already explained it, but heart failure with preserved ejection fraction. Many of us see the reports of diastolic dysfunction of echo, and as my cardiology seniors might agree, diastology is now an emerging branch as a subset in cardiology, and there is vast amount of research going on in the field of diastology, because many times you get a patient who has all typical symptoms of heart failure, who has all the clinical presentation favors diagnosis of heart failure. However, the ejection fraction is normal, and in such patients, when you go into detail, when you see the biomarkers, when you do the diastology or do the echocardiography, which is specifically to see heart failure with preserved ejection fraction, you get the answer, and that is heart failure with preserved ejection fraction. So, related to EF, nowadays with the European Society of Cardiology and ACC/AHA definitions, we have been running around with heart failure and its definitions. And right from 1990s to 2022, they have been shifting the goalposts, and they have been trying to define the heart failure, and yet there is no general agreement or general consensus between the European and the Americans regarding the definition of subsets of heart failure, that is heart failure with reduced and heart failure with preserved. It was easier for us that it could be only two, that is HFpEF and REF, that is heart failure with reduced ejection fraction. However, to confuse us further, they have come up with a new terminology now, that is heart failure with mildly reduced or mildly impaired ejection fraction. So this has been the progress of various trials of all these societies who have been trying to define and understand heart failure. And this also underlines the importance of heart failure, because the mortality, morbidity associated with heart failure is vast, and hence the research which is already going on in this field is also very large. Historically, HFpEF has been neglected, has been undiagnosed, untreated, and we had very less options available with us to treat HFpEF. And usually what we used to do till today or historically has been empiric. That is, we used to consider alternative diagnosis, be it accelerated hypertension or other comorbidities, or we can symptomatically treat patients with diuretics. That has been the mainstay of the therapy, even in HFpEF. We used to control the blood pressure and treat other comorbidities. And of course, the most important thing which we used to rely on for treating heart failure with preserved ejection fraction was rate and rhythm control, because many a times we used to get inappropriate sinus tachycardia, atrial fibrillation, various arrhythmias in these patients, or else treat ischemia, which was the most common thing or most easily achievable thing, and which was the most common etiology which we used to observe in these patients of HFpEF, that is, treat the ischemia, do an angiogram, check for blockages, and if at all, treat with invasive therapy. So these were all largely therapies which were available for HFpEF. So there were many unmet needs in heart failure, mostly HFpEF, because there were no treatment options available, and to date the treatment was relied on management of comorbidities and symptoms. Majority we used to treat symptoms and other adjacent comorbidities. Of course, we still don't have a complete answer for cardiorenal symptoms as well. Of course, RAS inhibitors and diuretics can be beneficial, but they can, in acute settings, they can also worsen the renal function. So there was a vast unmet need in the field of heart failure, and specifically in the field of HFpEF, that is heart failure with preserved ejection fraction. What is the data which was available for treating this particular subset of patients, that is heart failure with preserved ejection fraction? The data whatever the trials had been done till today were largely focused on ACE inhibitors, ARBs, and spironolactone, that is MRAs. And whatever the data showed, many trials, they studied perindopril, irbesartan, candesartan, spironolactone. The most important trial in this group was ALDO-HF1 TOPCAT. All of them showed that there was no difference in the clinical endpoints or MACE events in HFpEF. So majority of the trials were till today were focused on ACE, ARBs and MRAs, and they were largely non-beneficial or at the most equivalent to other therapies, and hence we were lacking that punch or lacking that final punch to drive the nail or to try to derive effective clinical outcomes in patients with heart failure with preserved ejection fraction. And meta-analysis, of course, RAS inhibitors were only the mainstay which was till today available for HFpEF. So now, with the advent of new molecules, and as Atul sir had rightly put it, like the advent of Hardik Pandya in IPL, so same thing, SGLT2 and ARNI, they have changed the landscape of treatment of heart failure. And ARNI have been like the newborn, that is the newer version of Sachin Tendulkar in cricket, that is Virat Kohli. So same thing, ARNI has been the newer version of ACE ARBs, which have changed the made a paradigm shift in the management of heart failure with reduced ejection fraction. And now I think all the colleagues and seniors will agree that all patients with ischemic heart disease, reduced ejection fraction, almost 90% of patients have already been initiated with ARNI. So that has been settled, the case has been settled there. What about the patients who have preserved ejection fraction yet having symptoms of heart failure? And so can ARNI be beneficial in this subset also? And there are, the thought process started in 2012. The Paramount trial studied that initiation of ARNI in patients with HFpEF, could they be beneficial? And earlier Paramount trial showed that there was significant decrease in NT-proBNP levels in these patients at 12 weeks of initiation of therapy. So biomarkers were significantly reduced. This was the first trial, that is Paramount trial, which showed us the guiding light in thinking that of course ARNI can be useful in HFpEF patients also. Initially, the Paramount demonstrated that NT-proBNP levels were reduced at follow-up, and in 2019, Paragon HF trial, which specifically compared sacubitril valsartan with valsartan alone in patients with heart failure with preserved ejection fraction, that is HFpEF. And although there was no reduction in primary endpoint, of course CVOT endpoints were not reduced, but there was significant improvement in functional class of patients, that is patients were symptomatically better, their quality of life increased, and of course the biomarkers were already proven that the biomarkers improved after initiation of ARNI. So if you look at the composite group that in these patients, ARNI were beneficial in improving the quality of life, improving the NYHA functional status, and of course were useful in improving the biomarkers, that is reduction in biomarkers. So a pooled analysis was done in patients who had ejection fraction above 50, and the results were that primary cardiovascular endpoints in primary pooled analysis of worsening heart failure, in ARNI they were compared with valsartan, and they showed significant positive results in reducing hospitalization related to heart failure and reducing the symptoms related to heart failure. So those soft endpoints, both of them were significantly reduced, and as was rightly said, India is the capital of diabetes and heart failure. Even though the primary endpoints have not yet been achieved or reduced, if you are reducing the heart failure admissions, you are reducing the economic burden of the patient, and of course you are indirectly treating the patient, and hence ARNI have been successful in demonstrating that you can reduce the hospital stay or recurrent hospitalizations in patients with HFpEF. So in 2020, Circulation came up with article, and these therapeutic effects of ARNI earlier, which were specifically targeted to HFrEF, that is heart failure with reduced ejection fraction. Later on, the data suggested that across the spectrum of LV ejection fraction, ARNI have been useful, and which forced the FDA to expand the indication of ARNI, that is sacubitril valsartan, and they have at least somehow incorporated that in certain subset of population with HFpEF, you can initiate ARNI, and they have indicated that the definition itself they have changed, that to reduce the risk of cardiovascular death and hospitalization for heart failure, hospitalization, the word is important, with chronic heart failure, benefits are most clearly evident in patients with LVEF below normal. So they have they have changed the word below normal. Earlier it was ejection fraction reduced variety, and hence, yes sir. So ARNI definitely have shown some promise in this regard. What about SGLT2? And SGLT2 is the flavor of the season, and SGLT2 is definitely showing promise across specialties, be it nephrology, be it cardiology, be it endocrinology, and it's one wonder drug which is very first time it has been observed that it was launched in the market as an anti-diabetic drug, as an specifically a drug related to endocrinology, and after it was launched into the market in population, later on it was realized that it had a wonderful result in reducing the CVOT or cardiovascular morbidity and mortality, and people went back to the boardroom, studied again, and came back with new research that SGLT2 are now beneficial in heart failure, and it has totally changed the management. So can SGLT2 be beneficial in this subset, that is heart failure with preserved ejection fraction? Yes, we all know the mechanism of action of SGLT2. Most important thing is glycosuria. They increase the glycosuria and they increase the natriuresis. And the clinical findings are they reduce the plasma glucose, reduce body weight, blood pressure, and most important, what do you think that SGLT2 might be useful in heart failure? What is the rationale? Because what the research says is that they have SGLT2 increase the tuberoglomerular feedback, increase natriuresis, and by increasing natriuresis, they are having a positive feedback on cardiovascular filling pressures, and then they are giving, hence they are able to demonstrate beneficial effects in heart failure. So what was the rationale in exploring SGLT2 for treatment of heart failure? Nowadays they are treating it without heart failure, and very soon we'll be using SGLT2 even in patients who don't have diabetes. And why? Because they have demonstrated their effects not only in diabetics but also people who don't have diabetes. In those patients also they have demonstrated wonderful results even in hard endpoints like reducing the MACE events, reducing the mortality, morbidity, and of course the soft endpoints. And DECLARE-TIMI, which was the landmark trial which was published, which established that dapagliflozin, one of the SGLT2 molecule, has created a paradigm shift in management of heart failure in all three spectrums. Here we can see that heart failure with reduced ejection fraction, heart failure with M, that is no reduced ejection fraction or HFF, and no heart failure. So even in no heart failure subset of patients, the dapagliflozin was able to demonstrate benefits by reducing cardiovascular death and hospitalization due to heart failure. So irrespective of your LV function, dapagliflozin was able to demonstrate that it can be beneficial. So now SGLT2 has benefits across the spectrum of heart failure, irrespective of your ejection fraction. So what do current guidelines say? Of course, SGLT2 has broken the barrier, and first time in the guidelines you can say that SGLT2 have in the ACC/AHA 2022 guideline, it has got a 2A indication, directly jumping from nowhere to a 2A indication as a treatment for heart failure. And the ESC has gone even further, and ESC has given class 1 recommendation for SGLT2 for management of patients with preserved ejection fraction. So now we have SGLT2 as an established molecule which can help us in treating heart failure. And just to summarize, we have new armamentarium, new ammunition available with us in treating this very common yet untreated, undiagnosed condition of heart failure with preserved ejection fraction, and we should definitely utilize these new therapies which might prove beneficial in treating our patients with heart failure. Thank you for giving us this opportunity for speaking to you.
Thank you very much. I think all of these speakers have done a wonderful job.